in treatment or an unnecessary treatment. So we put these treatments together, we put a visual representation up, we looked at wire sequencing, timing, and we built these and we put them into our practice management software so that our teams have something that they can go off of, so that when one of my new team members is understanding, well, what comes next, what layer comes next, they can look off of a treatment plan and they can actually implement this as they go on. And this has been instrumental. I would urge everyone to do this in their practice, is to truly sit down, start with what is the most ideal treatment plan, and then start adding what happens if you have more crowding, what happens if you have a canine impaction, what if you have a class 2, what if you have a herpes, and they start to build. And it is a wonderful exercise in treatment plan writing, which helps us to understand this treatment. So it's something that we're going to talk about today. So let's look at this treatment outline. This is a simple class 1, 9 to 12 month Damon Ultima journey from beginning to end, from the day the braces are put on to phase 1, phase 2, and phase 3. So out of all of the stuff that we've done in all of these modules, this is the sum total of those modules. It's the timing, the treatment, the wires, the phases, and what we can expect. So you can see here that we start with an 014, we move to 018, we progress to 140275, go to phase 2, 180275, go to phase 3, finishing wires. So we're going to look at this again later when we talk about elastics and hooks. But before, let's just recap a couple highlighted items that are some of the largest questions that I get asked. Remember, smile arc and occlusal plane is about occlusal plane. It's not necessarily about where you put the bracket vertically. These brackets are designed for FA. Please, please, please start there and then figure out what you need to do. I would also argue to use some sort of measuring tool. Our eyes are great, but they throw us for a loop. When you look at your fingers from two different angles, they look like they're closer and further together. The same thing happens when we're looking at 11 o'clock at our teeth. So we use these gauges. We buy them from a company in New Jersey. They're all over the place, but we definitely anteriorly, vertically check every bracket, whether it's a position or a reposition. We use 3.2x loops with lights. My team uses loops, or Scoptic makes them. They're beautiful. I would highly urge you to use loops if you're trying to really dial up your treatment with Ultima. One thing that I was, alerted to in some of my presentations is that, well, your bracket positioning, you say you're putting them in FA, but your bracket position is gingival. Well, let's look at a case like this. This is a case where the girl comes in with shorter clinical crowns. Her anatomical crown height is fine. She has delayed passive eruption or thick gingival tissue. She's like 13 or 14. Actually, she was 14, 15 because she had her quinceanera, is the case that I show. But nonetheless, when I put the brackets on, I measured them at 5.5, which if you look at the center picture, those look like a gingival bonding. However, I didn't change the vertical position, but a week before we took the braces off, we did a laser gingival procedure to trim the gum tissues for this young lady before she had her special day. Now you can see that relative to the anatomical crown, those brackets are actually right at FA point. Now, they look different, left and right, same exact patient, same exact measure at 5.5 on the central, 5 on the lateral, and 5 on the canine. So just remember, when you're seeing these cases, there are times where you'll put the bracket right into the gum tissue on a lateral incisor. That doesn't mean that it's a gingival bonding. That means that that is, in fact, FA for that patient. And that's a little confusing. So, if you've got a clinical crown that is only 6 millimeters tall, you're going to have a bracket that's right next to the gum. But conversely, just imagine where that clinical crown ends. So it's very important to remember anatomical crown height and clinical crown height in FA. Stops are a big issue. People always ask, where do you put the stop, right? So you've got your first wire in. Just remember that stops hurt and help us. The idea of a stop is to prevent the wire from moving left and right in a passive system. It prevents wire pokes and return visits. But stops can also prevent tooth movement. So, for example, that picture on the left where it says stops hold the wire, you can see that I have the stops positioned 1 millimeter mesial and distal to the bracket. If I put those stops up directly against the bracket and there was a rotation in that central incisor, if that patient came back at 6, 8, 12, 20 weeks later, the rotation would never work out, because if you think about it, the wire itself has to travel through the bracket, and it takes more wire in a non-rotated tooth. So if you take those stops and you smash them up mesial and distal, you're never going to work out crowding or rotation. So a rule of thumb when we start is we just put the bracket, we put the stops 1 millimeter mesial and distal to the least crowded central incisor, and the lower we try to put one stop between the central incisors. If the interbracket distance is too low, then we pick one of the least crowded lateral centrals. Now, in the middle, you'll see the lower bracket. On the right, you're going to see where stops actually help us. What if there's a diastema? We've got a space. Well, let's use the stops to our advantage. If I put those stops mesial and distal to a central, there's a good chance that when this patient comes back, they're going to have a bigger diastema because of the posterior development. So to prevent that space from getting bigger, you can see that I put those stops mesial and distal to the centrals. Sometimes it'll be mesial and distal to the laterals or even to the canines. That's where we can use the stops to help us. This is a fun tidbit. Dr. Damon had designed the Ultima bracket for absolute function. If you look at the Ultima bracket from the bracket base to the front of it, it's not a taller profile, but they scooped out some of the material to allow for ties to be put around as far as C-chain and tie wings. The problem that I've seen is that in some cases, most of them are Div 2 cases or where incisors are highly upright. The central incisor, if it's thin, can find its way between the bracket pad and the bracket tie wing. If that happens, even if you have disarticulation stops, the central incisor will pop off the central incisor bracket. I've never really had that issue before. It's not that big of a deal. We found a solution for it. You can either take an O-ring and fill up the slot. We went one step further and we purchased these bumpers that we put on in cases like that. So when we first bond up a case, we have the patient use an anterior excursion movement. If the incisors fit into the brackets, then we put these bite cushions on. They stay on for about the first 1 to 2 visits, and then we take them off. So it's just a little tidbit of things that I've noticed. I just never noticed lower anterior brackets breaking before. It's the same pad, same glue, same doctors, same bonding protocols. And I think it's because of the way that we've got all this room now to tie, but that's created a little issue with the central incisor. So these help out. You get them from 3M. You don't need them all the time. Maybe 1 in 10 cases needs them. It's important to talk about opening space, right? Just because you have a fancy bracket doesn't mean that you're not going to overpower the system. If we cram things in this system, just because it controls teeth in 3 dimension doesn't mean that we're going to maintain the beauty of PSL. Remember, PSL is about passive self-ligation, light forces, really good biology, right? It doesn't mean just because we have a system that can control the teeth that we can overpower the system. So we still use these wonderful protocols. So we use NiTi coil spring from Ormco. We make sure that when we activate these coils, that we're activating them only about 2 millimeters or a half a bracket. And let me show you what I mean by that. So if we have a case that's very common, we have a case where we have a blocked out canine and not enough space for that canine to come through. Patient's going to come in, we're going to put the braces on, and we're going to go ahead and use a little ruler to measure between the bracket and the tooth. So in this case, it would be 4 and the 2. Now, I'm using the ruler as a symbolic gesture. We actually just cut a piece of coil, mark it, and then cut it to length. But if I take that coil up and I bring it, and then I measure a piece of coil to mimic the space that we need. This is more for illustration purposes. If we bring that coil back, we know that it's not going to fit. So we have to compress the coil. Well, when you compress the coil on an 014 copper NiTi, as long as it's gentle, we're going to get posterior lateral development. The teeth move. Patient comes in at visit 2. Do not be tempted to put a stop on the wire. If you put a stop on the wire, what's going to happen is you're going to bind the system. If you put the stop mesial to the 4, you're going to flare the central incisors. If you put the stop distal to the 2, you might laterally flare the bicuspid. So we want the system to move in its entirely passive. So we're just going to pull the wire out, pull the coil, put a new coil in, and then we're going to create that space. Remember, this is important. We're creating space for canines and we don't want to flare teeth. So keep it light, keep it consistent, a couple millimeters each visit. Within 3 visits, you're going to have the 6-7 millimeters you need. Visit 3, measure, cut, new coil, put it in. By visit 4, we can add the bracket, engage the wire, 014 copper NiTi, bring that tooth into position. So be very careful, be purposeful, don't overpower the system. This is an example of that. You can see right here, we had a blocked out canine. We used the open coil, retrocline brackets. We probably took 3 visits to get the space for this canine, added the canine bracket, and brought that tooth into position. And you can see the same thing here. Nitide coil springs. We showed this case before. Nitide coil springs to create space. Once you get the space, activate those. Only 2 millimeter activation. Now, that is space opening. What about space closing or consolidation? Well, space consolidation is important. I've seen people use elastic thread. I've seen people use closed C chain. I bought a force gauge and I realized something that I was doing wrong. And because of that, we changed our protocol. So we actually do use different C chain in our practice for different purposes. It sounds like it's a nightmare. It's not at all. We use generation 2 wide C chain for all upper space consolidation, 3 to 3. We use generation 2 open C chain for all space consolidation, lower 3 to 3. And then we use generation 2 closed C chain for all things TADs. It's smaller profile. You can fit it around a TAD twice. We use these 3, and all we do is we cut sections of 6 and put it in our drawer. So if we're C chaining upper 3 to 3, it gets wide. If we C chain lower 3 to 3, it gets open. And if we do anything TADs, it's closed. Now, why? Well, the reason why is because I bought this force gauge. Dr. Damon and I were talking about forces and how we want to keep things super passive. And I don't really like taking threads and tying them. I think it's hard for me. I want to keep things simple, but I also don't want an overpowered C chain smushing the PDL together. So I bought this force gauge and started measuring everything. And what I did was I measured the 3 to 3 and 6 to 6 segment. And then I cut 6 and 12 unit C chains. And I did it for a variety of C chains in different lengths. And what I found is that it matters. If you use a closed C chain and you C chain at 6 to 6, it generates a tremendous amount of force. So what I found was using wide upper 3 to 3, I could generate 230 grams of force in an anterior segment. Couple that with a 2-ounce elastic right and left, and I'm within the biological limits, because what I was very much trained to do out of residency was C chain 6 to 6 with closed C chain, which is 1,134 grams of force if you add 6 ounces class 2 elastics. That is a kilogram of force. No wonder the kids cringe when we put this stuff on. What I find is if I'm using wide C chain on the upper 3 to 3 and I'm using 2-ounce elastics, that's only 294 grams of force. Divide that, that's a manageable amount of force. So I do like using purposeful C chain. Ormco sells it. It's easy. It's not more C chain and it's super easy to manage. So, and besides, my patients love it. Another pearl, the spin tech tool is called the spin tech tool for a reason. It's because it goes in the slot and you spin it to use the bracket as a reciprocal anchor to open the door. We had a couple junior clinical specialists, and what I saw was they were putting the tool in and they were pulling down the door. Well, not only does that hurt the patient, but that can also dislodge the little nickel titanium pin that holds the door in. So if you have your doors breaking, which never really happens, check and see if people are using the spin tech tool right. Everyone calls this the Damon tool. We actually did a little game in our office, and I think we gave some little gift card to somebody who could name what it was and what it was for. But the spin tech tool is to put it in and turn it. Use it properly. It's going to change your patient's experience. Okay, so those are some pearls. Let's get on with the title of this, which is elastics and hooks. So now let's get back to this treatment journey. When do we add elastics, right? So the entire debate of elastics has been early and light forever, right? And I've talked to Dr. Damon about this extensively. I understand now where that came from. I was right on the junior version when that came in. I was a 29-year-old, 30-year-old orthodontist going to my first Damon forum, and they were talking about early and light. And I'm like, wow, that's cool. I'm like, I want to start doing early and light. So from the time I started Damon in 2004 and 5, I started using early light elastics. Now that journey was great. I justified it. I explained it. I loved it. It worked. What I didn't realize was that I was round tripping teeth and I was preventing posterior development. And I understand that now, not because Dwight Damon told me, not because Ormco said it. It was because we saw the cases. We saw all these cases with photos every 4 weeks. We saw them constrict in the buccal segments. And then once we put in the bigger wires, we saw them re-expand. Now, if we just would have waited on the elastics, we wouldn't have had that problem. So when to add elastics? I'm going to lobby that you wait to add elastics until you get to 140275 copper nitide. It really isn't that much of an issue. We took about 20 cases and we waited to add elastics. And after those 20 cases, I was sold because it's so great not adding elastics the day you put braces on. The day you put braces on, they're not even listening. They're like freaked out. They don't know what to do. They don't know how they're going to eat like a sandwich. You're teaching them about brushing, flossing, hygiene, telling them their teeth are going to fall out if they don't brush their teeth. They are not worried about elastics. And when we stopped doing that and we said, hey, you're going to learn your elastics in 1 or 2 visits, don't worry about it. You have plenty of time. Our mornings got much better. So my team loves it. I love it. And honestly, right now, the clinical cases show that adding elastics at 140275 is great. Secondly, where do you add the elastics? Preferably not to the tooth. When you add an elastic to a tooth, it rotates the tooth and binds the wire. So Ormco and Dr. Damon have worked tirelessly to develop a hook that works really well, that isn't off-brand. In other words, you don't have to go somewhere else to buy it. Ormco now provides an Ultima hook that is a nickel titanium hook that can bend around the wire, and we'll talk about that. So let's talk about it. This hook has a lot of promise. They're new, so obviously there's going to be a learning curve, but the promise of this is that it is a hook that will not move on the wire. I've used a Trillium hook for the last 8 years. It is a NiTi hook that snaps over the wire that does not move. This is going to be a challenging product, meaning it challenges the Trillium hook, but it does have advantages. The Trillium hook, when you snap it on, you can't move it. So on the bottom left, you'll see a Trillium hook by Speed. That hook's great. I love them. I use them. It's nickel titanium. It's the best hook on the market. It actually does what it's supposed to do. They snap. You don't crimp them. You could take them off, but they're expensive. And you can't get them close to the tooth because the plier won't allow it. So when Ormco and Dr. Damon were trying to invent something that is better, they said, well, why don't we invent a hook that you can get all the way up to the bracket so that then once you've consolidated your anterior spaces, you don't have to ligate it with steel. We all know what happens. If you look at that bottom left picture, I've got a steel tie from the 3-2-1-1-2-3. Now that's fine, but it collects food. It's unhygienic. If I have to IPR, I have to take it out. If I have to repo, I have to take it out. I always have to put it back in. If I can take a hook and slide it up against the 3, I can keep that space closed. If I IPR 3-3 and then I have to power chain, I can then take this plier and slide that hook over, and it works beautifully. So we were in the testing phase of this. They work great. I think they're available now. In all disclosure, I just made my first order for I think 10 boxes of these things. So I can't wait for them to come out. Not every case will need it, but they are going to be integral in our practice to keep it clean and easy, simplify what we do. So that being said, when we do need elastics, let's hook them up from the wire, not the bracket. Remember, if we hook it up from the bracket, it's going to put a rotation on the bracket. That's going to bind the wire, and that's going to inhibit tooth movement. If we put the elastic on a hook, there's more anchorage against any sort of negative side effect. You're not causing a tooth to rotate. Again, we keep things simple in our practice. We only use 2 types of rubber bands, and we keep things light. So we use Quails, which are 2 ounce, 3/16. We use those for all things AP. Class 3s, Class 2s, hook to 6, hook to 6. Previously, we did 4 to 6, 4 to 6. So if it's a Class 2, it's upper 4 to lower 6, lower 4 to upper 6 if it's Class 3. But now we're actually going to be looking at using these Ultima hooks because we can put them on 140275, and we can start our space consolidation. We can start our Class 2 elastics. When the patient comes back in, we can move those hooks mesial if we still have space. I mean, it's just a beautiful system. Once we get to 180275s, typically we'll knock up a little bit. We'll go to a 3.5 ounce elastic, which is the 3/16, 3.5 ounce rabbit. Those are the only 2 elastics we use. We use rabbits for cross bites. We use rabbits for verticals. We use rabbits for essentially, power up on the quail. But still, it's only 3.5 ounces. So we're only looking at about 75 grams of force or 80 grams of force, which is quite nice. Rabbits also come in color, just so you guys know. So if you have those kids that are like, I want colors, we try to incentivize them by wearing the rubber bands and give them colored elastics. So those are the elastics we use. We keep it simple, and really that's all we need. Space closure. We talked about space opening. We talked about space consolidation. We've talked about holding space with Trillium hooks. Now, how do we close space? We're very, very regimented. If we have a space distal to the canine and it is greater than 1 millimeter, we're going to go and put a 125 gram, 12 millimeter NiTi coil spring on that. Ormco sells them. That's all we stock in the drawer. Now we do carry 9 millimeters in case we had somebody who had previous bicuspid extractions and we're trying to develop, or if we have a case where we have to put that a NiTi coil back to the 7, we do carry 15 millimeters, but we do not put those in the drawer because I don't want a junior level clinical specialist accidentally putting the wrong NiTi coil spring on. If you take a NiTi coil spring that's 9, you stretch it from the 6 to the post in a non-extraction case, the force levels go to like 700 grams. I mean, these are NiTi, but they don't have a modulus elasticity that is linear all the way through. They get really heavy if you overexpand them. So for that reason, we only stock 12s. We activate those, trim the wires. Once we have the spaces closed, NiTi springs come off, tieback modules go on. So we're very regimented on how that works. It's clean, our team understands it, and it's amazing. Sorry, excuse me. Okay, so back to our treatment plan and summary sheet. I told you that there was a second part to this. There is a downloadable file that I'm sure Ormco will be able to give you. If not, we have it on our website through a learning module. So either way, we'll find out ways for you to get it. The front of this is all about the ultimate journey. The back side is all about ways to increase clinical efficiencies. No orthodontist likes return visits. It destroys the beauty of Ultima System. If you can treat somebody in 7 or 8 appointments, but you have them back in 11 or 12 because you have wire pokes or doors not closed, I mean, that just drives us all crazy. So we came up with a 6-point check. This 6-point check is administered by another clinical specialist after the appointment's completed. So, you know, now that we're out of the COVID scare and people are okay with other people coming through, when our clinical specialist is finished, they use a light system to call over another clinical specialist. That clinical specialist gloves up, puts the loops on, throws the light on, and goes through all 6 of these steps. First being, they verify the upper and lower midline. That's the most important thing before you start to check the second, which is making sure the stops are secure. If your midlines are centered and your stops are secure, now you can go to the third, which is checking all 4 corners for wire pokes. Make sure that they're awesome. Make sure that there's nothing poking. If you need a comfort bend, do that. If you need to bring a greenstone out and polish that wire, make sure the patient is comfortable before they leave. But midlines first, stop second, or hooks. Third is ends. Fourth, make sure that every bracket door is closed. Nothing will destroy your Ultima efficiency as having somebody come back with a couple doors open. You have to go all the way back down, and you can waste 4 or 5 months with an error like that. So in the picture that I showed before, where I talked about the SpinTech tool, you'll see the little daemon wings of the door. We kind of refer to those as the devil horns. If you see a case on a final check and you're looking for the doors being closed, look to make sure that those little horns aren't poking out, because that is going to be something that's going to cause you a problem. That means the door is not fully closed. So make sure the doors are fully closed. Lastly, we look at hygiene. We grade it accurately and effectively every visit. And the last one is make sure if your patient is wearing rubber bands that they leave with them in. If they say, well, I'll put them in the car, don't let that happen, because you now are condoning bad behavior. We are here to coach our patients. We're here to get them to the finish line. Our journey is their journey. The journey needs to be coincide. So we need to coach our patients. We need to do a better job. This we have printed on the back of every one of our treatment cards, and our team does this for every single patient. With that, I am going to conclude. I thank you, and I want to really welcome you and also congratulate you on finishing this.